I will be presenting a study conducted in northern Ethiopia on accuracy of caregiver-performed MUAC measurements. The study was funded by UNICEF Ethiopia, while the operational research was conducted by Medical Teams International. And it has targeted 2 regions in Ethiopia, Amhara and Tigray. There is ongoing insecurity in Amhara region, while there has been 3 years long war in Tigray that has disrupted health system, displaced populations, and created barriers to accessing essential nutrition service. 90% of the health facilities in Tigray are not functional or were difficult to reach due to damaged infrastructure, insecurity, and transportation challenges. Conflict negatively affects HMAC coverage by destroying health facilities, disrupting supply chains, and creating security barriers that prevent access. It also leads to a staff shortage and demotivation due to low pay and dangerous working conditions, making it difficult to deliver consistent service. Due to this and many other factors in Ethiopia, malnutrition screening coverage remains very low to less than 10%, while community-based approaches such as family MUAC reduce reliance on distant or inaccessible health facilities, ensuring continuity of care. What is unique about this study is the fact that it has tested the family MUAC approach in the conflict context. So the objective of the study was to assess accuracy of caregiver-performed MUAC in conflict context and identify factors influencing correct measurement in Amhara and Tigray. Proceeding to the methods, a community-based cross-sectional study was conducted, and a total of 390 caregivers were engaged in 2 districts from northern Gondar and Amhara and 3 districts from northwestern Tigray region. Medical Teams International provided training and MUAC to those targeted mothers, while the training module used a comprehensive visual demonstration of key concepts and practical session considering the area targeted are remote and many of the mothers are not educated. And proceeding to the analysis, weighted kappa was used to determine the level of agreement and sensitivity, while logistics regression model was used for predictive variables of caregiver MUAC accuracy. The study found strong agreement, which is 0.9, between the caregiver measurements and the gold standard, which is health worker measurement. And to look down to the level of agreement between the different categories of acute malnutrition, very high agreement was found for normal and moderate acute malnutrition, while low agreement was found for severe acute malnutrition. And having older child, specifically having a child aged 24 to 59 months was found to be one of the predictors for correct measurement, while frequent practice of MUAC measurement, specifically daily and weekly practice, was found to be a strong measurement of accuracy compared with the irregular practice. And the finding from the study was consistent with other studies, which also found 3 or more times more accuracy among caregivers who are having older children, and also 13 to 24 times more accuracy with mothers who are practicing family MUAC or MUAC measurement on daily and weekly basis. So the study concluded that caregivers can identify malnutrition and even place the MUAC on the right position, and they can effectively interpret color regardless of their literacy rate. And the study found that having older children and regular MUAC measurement practice are significant predictors for measurement accuracy, while caregivers can effectively support in early identification of severe acute malnutrition from their home. Regular demonstration of MUAC for caregivers also can result in higher accuracy according to this study. And to see the operational significance of this study, caregivers can identify malnutrition in conflict context, where insecurity made physical access to health facilities impossible, increasing nutritional service coverage, and is also a recommended approach for scale-up. But the following operational customizations are also recommended to be considered for operational significance. The first one is developing visual and practical training material that are accessible to low literacy populations, and also encouraging routine MUAC checks at home through behavioral change communication, and providing reminder tools so that caregivers can practice measurements regularly. Those tools can be context specific, like that of calendar, mobile prompts, peer reminders, or other methods that apply to the context in target to reinforce regular practice. And also tailoring the training to address challenges in measuring younger children is one of the recommended operational customization, as we have found that caregivers were found to conduct accurate measurements, especially when they are having younger children. And also considering age-specific guidance and support during caregiver training session is recommended, as we are seeing child age as being the significant predictor for caregiver measurement accuracy. Thank you. This will be the end of my presentation, and I will be coming back to you to address your questions later.